Welcome back to the second part of the mini course. If you missed part 1, you can always go back. Remember, in part 1 we discussed the female pelvic anatomy, including the bladder, the uterus, the bowel and the ovaries. We also showed you how these structures look on ultrasound. Do you remember this image? Very close to the transvaginal probe, we see the cervix and the uterine body. To the right, we see the urinary bladder. In the midline of the uterus, we see the white hypoechogenic line, the endometrium. When you move the transducer to the left or to the right, you will find the ovaries to both sides in give you tips on how to find the ovaries in patients where it's not that easy, for example during menopause. Are you ready for more? In part 2, we are now going to discuss the correct diagnosis is to understand the female menstrual cycle. There is a complex interaction between hormones and female organs. Once you get the main principle right, it's not hard to understand and remember. This will also be fully explained during the bachelor class. In brief, female hormones trigger both endometrial growth and follicular growth, which can be seen on ultrasound. So let's start with the endometrium. The premenopausal endometrium undergoes cycling changes every month. So you need to know the stage of a woman's menstrual cycle to correctly interpret your findings. For example, during menstruation, the endometrium is very thin. During the first half of the cycle, the endometrium constantly grows. After ovulation, it transforms and prepares for implantation. But be aware, even that the endometrial thickness correlates to the stage of the menstrual cycleness. But pathology also plays a role and can lead to thickening of the endometrium. Furthermore, it's important to measure the endometrium correctly. It has to be measured on the sagittal plane, perpendicular to the uterus, at its thickest part. Here's an image to demonstrate this. Here's an example of the endometrium during the early proliferative phase. The endometrium can be seen as a bright echogenic stripe comprising of the basal layer of the endometrium. In contrast, this is an example of a woman in the late proliferative phase where the endometrium has already started to grow. In this phase, the endometrium appears in a trilaminar fashion. It comprises an outer echogenic basal layer, an hypoechogenic functional layer, and an inner echogenic stripe at the central interface. Care should be taken not to include the hypoechogenic myometrium or intrauterine fluid in this measurement. The measurement always needs to be accurate, especially in the postmenopause. The reason why this is so important will be discussed in the bachelor class. Finally, in the secretory phase, the endometrium can reach up to 16 millimeters. By then, it loses its trilaminar appearance and appears uniformly echogenic. In parallel, we also see changes in the ovaries. The ovaries contain follicles that appear as fluid-filled sacs. During the natural cycle, you can easily apply the 1-2-3 rule. The visible follicles on ultrasound can have up to 10 millimeters in size. The dominant follicle can reach up to 2 centimeters. When the dominant follicle does not rupture, an ovarian cyst can occur. This is then larger than 3 centimeters. Let me show you how this looks on ultrasound. Irrespective of the menstrual cycle, follicles appear as fluid-filled sacs. Ovaries appear moderately echogenic, and the fluid-filled sacs can be seen as black dots on the ovary. On this image, we also see the iliac vessels, a landmark to find the ovary. In the course of the menstrual cycle, one follicle is chosen to become the dominant follicle. Remember, the dominant follicle reaches approximately 20 millimeters. When this follicle ruptures, the ovarian cycle enters its luteal phase. The ruptured dominant follicle undergoes physical changes and produces a structure called the corpus luteum. Here's a color Doppler image which allows you to display flow. We can see the ovary and the iliac vessels. When you turn on the Doppler, you see a circular vascularization around the corpus luteum, the so-called ring of fire. If implantation does not occur, a few days later, the menstrual cycle starts over again. So these are the most important aspects of female physiology. You see, it's not that complicated. Let's move on to pathology now. This schematic gives you an overview of the most important pathologies causing abnormal uterine bleeding. They can be categorized in either structural or non-structural in nature. The structural causes for abnormal uterine bleeding can be seen on ultrasound. Non-structural causes, as the word implies, cannot be seen on ultrasound. In this mini-course, I want to focus on the most important causes for abnormal uterine bleeding. Let's start with the polyps. Endometrial or cervical polyps are usually benign proliferations of the epithelium and stroma with variable vascular, glandular, fibromuscular, and connective tissue components. Endometrial polyps are a common cause of postmenopausal bleeding and can also be frequently seen in patients receiving tamoxifen. Endometrial polyps are a common cause of postmenopausal bleeding and are also frequently seen in patients receiving tamoxifen, a medication that is given to breast cancer patients. The most common symptom in women with endometrial polyps is irregular uterine bleeding that can occur independent of the menstrual cycle. Here's such an example. Polyps appear echogenic, homogeneous, and sometimes you can see cystic changes within the narrow base of the attachment. By adding color Doppler, you might see a vascular pedicle. In this image, the diagnosis of an endometrial polyp is quite obvious, but it's not always that easy. You might need color Doppler or hydrosonography. These are more advanced techniques, and we will show you them in the bachelor class. Another very common cause for abnormal uterine bleeding are fibroids or so-called myomas. On this image, we see an anteverted uterus with two fibroids in the anterior uterine wall. Myomas usually appear less echogenic than the endometrium and form so-called pseudocapsules. These pseudocapsules are formed of compressed surrounding myometrium. In my experience, it's quite easy to see the myomas or fibroids on ultrasound. However, the true art is to know how to manage them, and here ultrasound can help. It's a bit more complicated when it comes to the correct diagnosis of adnexal pathologies. The reason being is that there is a serious concern when an adnexal mass is discovered, because there is the possibility that it is malignant. Therefore, the International Ovarian Tumor Analysis, the so-called IOTA group, was founded more than 20 years ago in the Netherlands. They have published numerous papers about classification system and scoring of ovarian pathologies. One of the first papers was about the classification system for ovarian pathologies. Later on, they reported recommendations for assessment and management of adnexal masses. There are different assessment approaches of adnexal masses. The first is using pattern recognition. That means you see a structure in ultrasound and should be able to make the diagnosis. The second approach uses risk prediction models with an emphasis on the Iota simple rules. Adnexal masses can be categorized in these 4 groups. In this mini course, I want to focus on easy to diagnose and common findings. Here we have a dermoid cyst or so-called teratoma. They are one of the most common types of cysts in young women. A dermoid cyst can consist of ovarian germ cells and can contain teeth, hair or fat. This results into a mixed echogenicity with posterior acoustic shadowing, which is a loss of the ultrasound signal behind the structure. Another common finding are women with polycystic ovaries. On this image, we see an ovary with lots of follicles. To count the number of follicles, you would need to scan through the whole ovary. If the follicle count is above 20, you might suspect PCOS. However, the exact pathway of diagnosis will be explained in the bachelor class. Here we have a cyst that is called an endometrioma. An endometrioma is a benign cause of an adnexal mass arising from ectopic growth of endometrial tissue. The ultrasound of such an endometrioma is often described as ground glass. These cysts are called chocolate cysts because their fluid contains old blood which has a brown color. Sometimes you might come across adnexal masses that don't originate from the ovary, like in this example. Here we see a hydrosalpinx. A hydrosalpinx results from a fluid-filled dilatation of the fallopian tube. The folds represent the classical cogwheel appearance. And these folds are pathognomonic for a hydrosalpinx. Sometimes the description of an adnexal mass might be difficult. Therefore, it's important to know how to describe the terms, definitions and measurements of adnexal masses according to this important IOTA publication. So you see, there's a lot more to learn. But there's one more parameter I would like you to know, ascites. Why is this important? Ascites can sometimes be associated with ovarian cancer. Ascites, according to the IOTA definitions, is fluid that extends beyond the pouch of Douglas. Here's such an example. You don't only see the ascites behind the uterus, but also in front of the uterus. As I mentioned before, this can be associated with ovarian cancer, like in this patient, where you have a large pocket of ascites in the abdomen that can also be seen on the transabdominal scan. In order to improve your ultrasound skills in gynecological ultrasound, it's necessary that you chase the results after, for example, surgery and compare your findings with histology. Let me give you a few final tips. Keep practicing and chase your results. Compare your findings on ultrasound with other imaging modalities and/or to histology. And that way you will improve your gynecological ultrasound skills. I hope you enjoyed this lecture, but we are not done yet. There's another one coming up, covering obstetrics. Here you will meet Dr. Rebecca Ertl, a good old friend of mine and an absolute expert in the field of obstetric ultrasound.